Hello, and welcome to our webinar, The Three Pillars of Successful Population Health Management: Providers, Leadership, and Data. First, before we get started, let's just go over a few housekeeping rules. We will be taking questions at the end, so please, throughout the webinar, please enter your questions in the chat box, and we will use those questions to ask our panelists your questions at the end of the session. So with that, and no further ado, I am Dr. David Nash, Chief Medical Officer here at Innovaccer, and I am pleased to welcome our esteemed panelists. First, I want to welcome my friend and colleague, Dr. David Nash, the founding Dean Emeritus at the Jefferson College of Population Health. And I've known David for nearly 30 years. He was just amazing at starting the first school of population health, and now the first college of population health, and now the founding Dean Emeritus. David, welcome.
Thank you. Great to still be kicking, too.
We can all say that. And then also very pleased to introduce Dr. Jesse James. Dr. James, the Chief Medical Officer at Chest Health Solutions, and we're going to learn all about Chest Health Solutions today. Dr. James has a long history of cutting his teeth in population health management and value-based contracting strategies, both at Evolent Health as a consultant, and then prior to that, doing work in the federal government as well. Dr. James, welcome.
Thank you so much, both Davids. I'm happy to be joining. Looking forward to the talk.
Awesome. So with that, let's get started. So David, we at Innovaccer, we get these tremendous turnouts for our webinars with such esteemed panelists such as yours. We've been able to survey over 3,000 leaders in the healthcare arena, both providers and payers and some other folks, government agencies, around kind of where they're at with population health. So if you look at the providers themselves, what we see is some people haven't really get started. Maybe 20% really haven't done anything. They're just learning. Another 60%, have started to implement pilots and other things. We'll get into that a little bit later. And then others are starting to feel like they're learning to pedal the bike. With your view at the School of Population Health and as a leader in this space, where do you see us today in terms of this journey to population health management?
Well, first of all, David, thanks again. Jesse, great to meet you, and thanks for all of our colleagues who are on the line with us. So look, David Nash, I'm impatient, and you and I have chatted about the state of affairs before. I think looking at the first slide, sure, about 60% of folks have implemented some aspect of population health management. But you and I know this means lots of different things. Some of it could be just a value-based contract. So I think this is about where we are. About half of all providers are doing some value-based contracting. I think that's about the state of the nation at this point.
That's right, and I don't think that value-based contracting they're doing is necessarily enterprise-wide. That's correct.
And I think Jefferson Health is a good example. Hold on, we're getting some feedback here too. I think
James,
Jefferson Health.
Go ahead.
Yeah, Jefferson Health is a good example of about 20 hospitals, and we're just in a slew of value-based contracts trying to create our population health strategy. And I have confidence we'll do it, but it's just taking time.
No, that makes sense. And, Dr. James, the focus of this webinar is really around contracting, right? So population health management is really the cornerstone, I believe, of any value-based strategy. Would you like to say a few comments about that, on your view on that role of population health management in value-based contracting strategies?
Oh, absolutely. Here at Chest, contracting is really key to our success and key to what we've been able to do. But to some extent, what contracting looks like is dependent on what stage an organization is, along really the framework set up in your previous slide. So they're the curious uninitiated medical systems who aren't entirely sure what to do, how to act within value business, or how to work within a population health framework. And then there are the early adopters who have put in some of the strategy and tactics, who perhaps have set up an EMR, perhaps have set up a population health management health IT system. They might be involved in episodic care and upside risk, but haven't really dipped their toes into the downside. And then there are really the experts who put in time, who probably learned from some early mistakes and are able to adjust their contracts, whether they're inside of the federal space with Medicare or Medicaid or inside of commercial business, are able to adjust their contracts really to their own organizational strengths, really to leverage their health IT package to the work they need to get done. Another interesting thing is how the terms value business, value-based care, population health have almost become synonymous. Although from an academic standpoint, they are fairly separate. I'm sure Dr. Nash would agree, but the reality, to do pop health, you need the financial structure that comes with value business. So I'm really excited by seeing organizations along this different spectrum bring to bear pop health management in ways that you just would not have seen 10 years ago.
No, that makes a lot of sense. And, this idea of this cycle that we see here and I've seen this in many organizations, where you begin to model out using your data before you enter into a contract, and then you implement the contract and see if, as you measure the results, whether you actually achieve what you thought you would modeling, and then be able to kind of go back and renegotiate the contract or rethink your contracting strategy. Does that seem to fit with your experience?
Oh, absolutely. The data checks that are required, there's both descriptive and predictive analytics that you want before you get engaged in a contract. Honestly, you have to know as much about your population as possible. What are your chronic diseases? What's your estimated RAF score? How many patients do you expect to be presenting to emergency departments over the next year or month? How well do your care managers do at reaching out to patients within 7 days that they've been discharged from the hospital? How easy is it for a patient to into an office visit to see their PCP if they want to do a same-day visit? So all of these factors are coming into play, are going to be important within a contract. But then once you're implementing the contract, you have to be tracking those now descriptive analytics in real time, so you can get to a point of being prescriptive. So you're looking to see, in my mammography measure, I'm just 10 patients away from the next star cut point, and I have 4 weeks to deliver on that. So having analytics that match the contract and then adjusting your operation to those analytics are key to winning inside the contract. Not necessarily every ACO or every system that's in that earlier part of the growth and experience curve are really going to be able to bring these type of analytics or even the operations to bear. You can have the descriptive analytics, but if you don't have your ops to organize around them, you'll end up disappointed come end of the year.
Wow, that's amazing.
Yeah. Hey, David Nace, I just want to jump in. Jesse's done a great job explaining the contractual obligations and the data that you need. But I think we ought to take a moment, population health versus population health management, we're still defining our terms even in the marketplace today. And I think most of our listeners would agree that most of the ACOs are still struggling, even as CMS is introducing more sophisticated models, more risk for everybody. I mean, I think our overall performance up to this point, I'd give it like a B+, and I'm an easy grader.
Well, David, I'm really glad you mentioned that, CMS and the feds have tried these different models. I want to point out, and you and I were talking about this earlier, this is the 10th anniversary of the Affordable Care Act. So we've had a journey along the way with the feds trying to play driver's seat role. Can you walk us through this, Dave?
Yeah. Well, this is a great slide. I wish I had somebody like this for our students. But I think our listeners know that this has been a pretty bumpy journey for 10 years. And most of the published evidence would say we're still just making modest progress. You know, to me, the summary of all of this is, look, if you put providers at economic risk for clinical decision-making, they will change their clinical behavior. We knew this going back to 30 years ago. But manipulating these economic incentives, including specialists, this is really going to be the key next wave. And couple that with electronic medical records, better data, tools like Innovaccer, then you'll get examples like Jesse was able to describe for tryst. So, we're still early in the journey, even though it's been a decade. And this is a great slide just to show the rollout, and especially most recently last year with APMs and MIPS. But there's been very little published evaluative evidence on whether any of this stuff is working.
No, that makes a lot of sense, and it's a beautiful summary, and it has been a bumpy road. Jesse, what are all your views around the bumpy ride in these different types of value-based contracting? How do you see it from your vantage point?
So as David was describing the last 10 years, I couldn't help but wax a bit nostalgic and remember, like, more than 10 years ago, more than I'd like to admit than 10 years ago, I was a medical student sitting in lectures and hearing the likes of Bob Galvin talk about how when he was a medical student in the 70s, the mantra was, system is too costly. We don't have good answers on quality. This is unsustainable. And I found that a little bit depressing because I was thinking if it was unsustainable in the 70s, geez, it's been unsustainable for a long time. I thought all of this was new. As we look back over the last 10 years, there has been so much work to be done on moving healthcare in the U.S. to a different place that 10 years almost seems like a short amount of time for how we've been able to move. Like having options for payment reform in place, moving the majority of providers and practitioners from really being paper-based to electronic system-based. That happened really almost 3 or 4 years, and that came out of the economic stimulus. So when we stand back and think, okay, we haven't been able to perhaps bend the cost curve as much as we would like, but have seen it bend. But I think the foundation is in place, definitely. And what this slide is going to is sort of setting down how people step across this journey from volume to value. And on the left side, you see level one, which is where most of healthcare dollars still are spent. It's a place you can dip your toes in the water if you're that curious, interested health system or a newly minted ACO, where it's basically pay for performance with perhaps some upside, but fee for service plus, so to speak. And I really overlap level one and level two. Level two is almost level 1.5, which is primarily fee for service, but add a bundled payment, maybe some quality metrics based into that, some quality gates. But it's just the beginning of downside risk. Once you get to level 3 and level 4, that's where you're starting to see, that's where you'd place your Pioneer, your old Pioneer ACOs, MSSP, and Next Gen, where there's both upside and downside. Risk assessment during your contract years are going to be critical. Your ability to do predictive analytics on patients, whether they're in or out of your population, will be critical. Your ability to move clinical information from provider to provider will be as well. And then up to that 4 or 5 is where CMS is heading, and where, to my surprise and satisfaction and curiosity, a lot of the commercial payers say they are eager to go to global cap, and some payment models that are more innovative than capitation. So this can seem daunting and intimidating when you're living at level 1. If you're doing level 3 well, and you're one of those expert ACOs, then you're running at upside and downside risk because you're confident of your ability to score there, and you want to reap more of that benefit. Those folks that are running at the downside and upside risk are going to be the ones who will be early into capitation. But of things to get excited about, this excites me because I'm waiting and eager to see more of those level 1 folks dip their toes into level 2 and level 3.
Hey,
Wow,
David, thanks.
Yes.
I'm way more impatient than Jesse. I wish we were at level 4 right now, which is where we ought to be after a decade's worth of work. And look, the research evidence really does confirm that you got to get to the global capitation to really make a difference. And we know that.
Without a doubt, for sure. Hey, let's we've got right now almost 900 people in this webinar listening to you experts and loving every second of it. Let's ask our audience where they're at in this journey. So we're going to bring up a poll. We ask each of you to sort of just respond to this poll in your chat box. What is the status of your organization in terms of value-based contracts? Are less than 10% of your contracts value-oriented? Maybe 50%, like most of the world reflects? Are you only doing value-based contracts because you are the expert in your area and you've got it down, you've been doing it for a while, training wheels are off? Or are you still kind of watching and waiting and seeing if this is really something that you need to get into? So while we get into this poll results, because it's very exciting to find out what such a big audience is at, David, you are impatient, and I think we all are. We've been trying to kind of get the word out for some time. What do you think is needed to kind of move this forward in a much faster way?
Well, so let's go back to the theme of our time together and the 3 pillars: providers, leadership, and data. I think it's leadership first and data second. You've got to have leaders with real vision about what is the core business we are in. Is it to improve health? Okay, then if it's to improve health, we've got to tackle not just these contracts, but we got to go upstream, look at all the social determinants, get connected to the community. This is really complicated work. So to me, it's leadership first, and then second is we're only now connecting the dots to get the data that we need, as Jesse alluded to earlier. Look, like many of our listeners, I've been in primary care practice now for 30 years. I really don't have a good report card about my own performance. I really don't have a great registry function about my own patients, who's got what disease, how are we doing. So we still have a crying need for visionary leadership and better data.
Wow, you can say that again. And I bet you the kind of thinking that people in the field that are responding to this poll right now are kind of thinking about the same things. And here's the results.
Yeah. Wow.
Wow. So let's start with you, David, since you were on a roll. What do you think of these results?
Well, it's confirmatory of the first slide from 15 minutes ago, which tells me the market's still not moving all that quickly. Not a surprise. It's really fascinating given how many amazing colleagues are on the call with us at this point in the year. So basically, exactly what we have found previously. And I think it calls out for better data and visionary leadership to get us to the next level.
No, I couldn't agree with you more. And that really brings up going a deeper dive into that survey we did of 3,000 people. If you break out that 60% of people that are actually trying something, most of them are in pilot mode. A few of them are starting to scale, most of them, not quite. And then, others are rolling out. So these pilots can be pretty small. And Jesse, I would imagine all your years doing consulting and working with many organizations at Evolent and the feds, you've seen this sort of start very small and slowly expand. Is that right?
Oh, absolutely. It's a journey. Sort of back to the steps. When you're going along those steps, if you are too aggressive, you're at risk of missing on downside and losing money, and that will hurt a pilot, and it will lose momentum inside of an organization. And also, what's important here is to think not only of contracts, but really it's reimbursement. A deeper look is what percentage not only are your contracts value-based, but what percentage of your reimbursement has moved from fee-for-service. A lot of what we're calling value-based payment is still primarily fee-for-service with some quality bonus at the end. And I think the challenge of getting from that first to second step and moving to the third, you need a different set of incentives to move folks en masse because fee-for-service dollars are very comfortable, and it's what's driven healthcare in this country for a long time. To get to that third, fourth, and fifth step, we do need stronger incentives. I'm excited about the folks that are moving, but I know it takes more than a notion to move folks along the way.
No, absolutely. And we brought up this issue about data, how data is so important to be convincing to actually take that step moving forward. So let me switch to Dr. Nash. David, data seems to be critical to anything you do in population health management. What are the kind of things you want to know from your data?
Wow. Well, and this is obviously an open-ended slide. So we want to know as much as possible about our population. And we know that the social determinants that drive so much of utilization. Do you have a car? Can you get to the office? What's in your refrigerator? I mean, the kinds of things that I was never trained to ask, but my daughter, who's now a second year attending, she was trained to ask. So some of this is the data generational. We need a registry function built into the EMR. Who am I responsible for? How do I stack up relative to a local and national mean using process quality measures? So you have the population-based data and we have the performance-based data, and a way to sort of tie it all together, that's another crying need in the marketplace. Historically, also, we've laid all of the of the primary care doctor, and she cannot be the sole responsible person. We know this is a team sport, and so the primacy of primary care certainly is critical, but we also know that the team needs access to the data as well. So this is a tall order, which is why we're at the stage we're in still.
And I think you mentioned that was a very high-level, simplistic slide. Now let's get into some more complexity. So, yeah, here we go. So, Jesse, lots of different thoughts about the role of data. I think Dr. Nash got into some of it, but maybe you can say a little bit more about how important data is in various stages of moving across the contracting stages.
Right. Well, the fact that earlier slide with the view of high tech, ACA, ARA, that earlier slide gives you a view of what had to happen, even inside of meaningful use, the difference between 1 and 2 and what came after, what had to happen to create an environment and to have the tools that are necessary to do value business and population health. And this slide starts to go into that. But we could not be at this point without almost really an EMR plus. So to do population health, your EMR is often not enough, and folks in the space will tell you this, that the EMR was really architected to a single patient at a time to do documentation, maybe some limited analytics and clinical decision support. But what you want from a pop health tool is to think about not only the patients that are coming in, but the patients who should be coming in, not the patients who are seeking care, but the patients who haven't. So that's where you get to that middle rung, that I guess that's teal in color, of having having all three: descriptive, predictive, and prescriptive analytics. Your descriptive analytics are telling you who's coming in and who isn't, who are your high-risk patients, who has been costly. Your predictive analytics are letting you know who you might be or could be missing, who is going to be high risk over time that may not be now. Your prescriptive analytics are pointing you, it's almost pop health clinical decision supports. Or prescriptive analytics are telling you what to do based on what you've seen in your predictive model and based on the size of that population, how you should intervene. Having all of this data and all of these analytics together, the structure and architecture around this does not tend to only live in the EMR. In reality, tends to live outside of it. So the current state of a health IT package is multiple systems that tie in with your state social services, with social determinants of health, with your patient-focused platform, plus your EMR, plus practice administration system, to give you information you would not have otherwise, to point what is almost your army of folks that are working on this in the right direction, even to the point of to let your physician know that next patient that they're seeing, they have a RAF opportunity and they're high value from a quality measure point of view, in addition to their clinical needs.
Yeah, wow, that's a mouthful. Hey, David, yeah, I think among the challenges we have here are most of the language on this fantastic slide is unknown to most primary care doctors. Unless they have an opportunity to get educated on these issues, this I'm sure would be a foreign language to the frontline troops. And that's another big gap and another reason why we've had such modest uptake.
Yeah, I'm definitely with you there. What I struggle with is how much is appropriate to share from a conceptual framework or a conceptual point of view. I'm comfortable with the average physician not knowing the terms, but I think physicians get the functionality. I think you'd agree that there's a yearning for this type of information, but often it's not getting to the front line physician, and it should at least be getting to the care team, but not necessarily is making it there either.
Right, and I think the other thing I have to raise is the specter of unexplained clinical variation. You could have all the analytics you want, but if you don't close that feedback loop and give docs good information in a non-punitive way about their own performance and how it relates to the peer group, and they can see the variation and then see the gaps, that's half the battle towards reducing variation and closing those gaps. So I think the predictive analytics are great. I get it. But I think equally important is closing that feedback loop.
Oh, absolutely. Just the mention of clinical variation sets my heart aflutter. I wrote my med school thesis on clinical variation and Winberg's work. Right. But yeah, that fits under the descriptive analytics of letting providers know where they fit inside of their cohort of other providers.
Exactly.
And then the additional information. Okay, this is something that we often get from our providers. It's like, after you let me know where I am, then there's additional step of what can I do about it.
Exactly.
And
so
that's another level that often we don't get to.
Yeah, and again, I want to get us back to the three pillars. That's why I think the leadership pillar is primary, because it's going to take clinical leadership to help our colleagues understand how to reduce variation and how to close the gaps. You know, nobody comes to work wanting to be average. You know, we got that, but we have, regrettably, 30 years of health services research that says, we've got a bell curve distribution of performance, and to move the curve in the appropriate direction, it's going to take an awful lot of leadership.
Well, with that said, let's go on and take a lesson and learn a little bit about your organization, Chest Health Solutions. Dr. James, my opinion, you've got something brewing there, and you've got some great history to kind of bring to the organization to help that journey. Would you like to introduce us to Chest?
I'd be happy to. I think that was, David, the perfect segue into Chest. Speaking of clinical leadership, Chest is a physician-led organization that was physician-founded. We actually grew out of a physician organization, a large practice that was well ahead of the curve when it came to value business. And they invested deeply more than 12 years ago in the infrastructure needed for care management, pharmacy cost reduction, data analytics, an EMR. In the early years, the early years were not free of bumps, roadblocks, potholes, and because really the financial infrastructure that's there now was not there at the time, Chess honestly had a hard time gaining a foothold in the area, but their heads and hearts were in the right direction, and since have been very prosperous when it comes to savings, when it comes to building contracts with a group of provider systems in the area. At this point, we have saved $136 million. That $136 million is only the savings we have reaped as an organization, not including what we've saved our commercial and federal partners. We've partnered with local hospitals, medical systems, and we're almost like Match.com between them and their payers. We're responsible for making sure the contract is written and executed in a way that benefits them, and then responsible for that execution to a certain extent for bringing their care management, analytics, relationships with physicians, and really going deep into public health services for our value partners. We are eager to take downside and upside risks with our partners. I think because of that, the early experience we had to have, that scar tissue we had to take early on, we learned the lessons that other organizations would have to learn on their own. So we're able to take even small hospitals or small systems and match them with larger ones that can help shield them from that downside risk, while they also are able to score well on their quality measures and the risk adjustment.
No, that's amazing. And this is quite fascinating. Would you like to share with us a little bit about that journey from where you started and how you began to organize and reorganize the practice work for the clinicians themselves?
Oh, happy to. So Chess really started under the framework at the time was really focusing on the patient-centered medical home and how a primary care or multi-specialty practice could exist in a way that allowed your physician to allow her to work inside of a team around her to give support, to allow a patient to be able to orient towards that hub of primary care, to allow, as you improve your quality and as you reduce costs, to allow that home organization to reap some of those benefits. So all of these characteristics were foreseen early by the group at Chess. And the goal was to wait for the market to catch up. Over time, as we've been waiting for the market, or as folks waited for the market to catch up, we've increased the number of value contracts we've been under. We focused on chronic care, focused on relationships between our providers and our care management hub, focused on meeting patients where they are, and build out a very strong capability around social services and social determinants of health. And in the end, where we've ended up is not only maintaining our provider DNA, but allowing that DNA to propagate into other provider systems. And we've really become a mentor for systems who are, some of them just dipping their toes in the water on value business, like that level one, and others that have already contracted with employer and commercial systems on sharing savings and improving quality.
Well, it's an amazing journey. David, you know, this whole issue of leadership that you outlined as being so important, I mean, you can break down leadership in a number of different ways. It's population health management leadership, it's system leadership, right. And, you know, we build out data teams, it's analytic leadership, financial leadership, and it really comes right. down to this issue of, you know, connecting everybody and beginning to use these modern technologies and workflow automation, machine learning, artificial intelligence. Tell us a little bit about this concept of leadership more broadly and how it really plays out.
Yeah, well, thanks. I like to think that my 30 years on the faculty at Jefferson, you could really summarize that I've been in the business of training clinical leaders for the future. I mean, that's basically all I've done. So I think physician engagement in every aspect of data transformation, analytic, payment reform, our participation in this and education of physicians in all of these tools, with Jesse being a great example, that's what I've been about really my whole career. Putting this kind of learning earlier in the educational spectrum, as early as medical school, residency, that's what we've got to do to create a generation that will be very comfortable with this kind of feedback about their performance, closing the feedback loop. It's like the old line, if you give me a fish, I'm not going to be hungry, but if you teach me how to fish, that's a much better approach. So teaching through our college and the 10 schools that have been created since we launched our school, the journal, our textbook, proselytizing, our colloquium that's coming up next month. I mean, this is all part of the transformation to build the kind of leaders we need for the future.
Jesse, your thoughts here?
I am entirely with David. I am also very excited about the generation of physicians in training that have a certain comfort with sharing visibility and data tools. I think medicine and healthcare itself will benefit from an ease around tools that has not necessarily existed before. And I also think very strongly data is only the start, just by plopping down a pop health tool or EMR, it does not create a value business organization. And it definitely will not on its own allow you to save or improve quality just with a structure in place. That it comes down to leadership, it comes down to effort, and it requires sacrifice and buy-in on really everyone involved. But it's an exciting time. I stay with it. It's an exciting time to be in this space.
No, that makes a lot of sense. It's so exciting to hear the work that you've done at Chest and what you've achieved. And you have leveraged technology to help inform these leaders in terms of being able to be smart about what they're doing, about having intelligence in front of them to make these decisions. So let's talk a little bit about asking our audience where they're at in implementing contemporary technologies within their organizations. So there's a lot of buzz right now about artificial intelligence. It really encompasses a lot of things, machine learning, a lot of these advanced technologies. Everyone's hiring data scientists. Let's ask our audience, are you beginning to implement these contemporary technologies? Are you ready and you've got an implementation plan in place? Do you want to use them and you're really not sure how to get started? I would imagine there may be some people in that category, or are we not ready for any AI-related technology? David, I want to come to you because you and Steve Klaskow, leadership, I know you've done a lot of thinking about contemporary technologies and where you might go as a health system. Can you say a little bit about your views of artificial intelligence and where you think that might lead us in this journey in value-based contracting?
Sure, and I'm not an expert on the technology, but I think our listeners certainly appreciate that we have new technology now that enables us to scan gigantic data sets, create synthetic data, organize data the way Innovaccer does, and give us insights that we just would never have available before. And this is even being broken down on a specialty by specialty basis, probably starting with radiology, anesthesia, and other heavily data-centered specialties, all the way to the chaos of a primary care office. And so we have the learnings from predictive analytics now already in use that we could put into broader populations to make predictions. At Jefferson, we have an entire team, like a lot of big places, devoted to organizing this data, getting it back to frontline doctors. I mean, it's super exciting. And our industry is still playing catch-up ball, of course, to many other industries. So I think the sky's the limit for the kinds of new opportunities we're going to have.
That makes a lot of sense. Let's go ahead and pull up our poll results and see where our audience is in moving into this new world of artificial intelligence. Interesting.
Yeah, wow. So let's see. Let's do the math. So 60% aren't ready or don't know how to start. Wow. That. I think we're still early in the journey.
That's a great opportunity.
That's job opportunity for health data scientists.
Right.
There you go.
That's leading to the sense that you can't find these people because everybody needs to get started. I would add, David Nash, that I do think the payers are way ahead of the providers in their use of AI, machine learning, and augmented intelligence. No question about that, because the payers have owned this data for far longer than providers. So this does not surprise me, but it's very sobering.
Yeah, and I have to make a comment here, David. As you know, I've spent a lot of time with leadership for all the major payers around the country. One of the larger, if not one of the largest payers in the country, recently appointed somebody to get their arms around all these data scientist people. And he or she recently told me they had 3,000 people across the enterprise with the title data scientist.
Wow.
3,000. Unbelievable. So you're right. Payer side, they've invested a lot in this whole area. So interesting results for all of us to learn from. And, I think as we move forward, we really need to think about really this concept of a connected care framework. How do you use data to bring it all together to a unified data record and have everybody working on the same team to care as one? Let's start with David, and then we'll have comments from Jesse as well from the chess point of view.
Yeah, well, I really love this picture and the diagrams. To me, this is the holy grail right here. This is the Rosetta Stone, whatever analogy you like. And I sure hope I live to see this, because it would be a great way to practice for the future. Everybody on the same platform, provider and payer. I think that's on the left-hand side. And the link to the community that Jesse had brought up earlier, and the link to pharmacy and lab. Imagine our ability to do all this. And, Innovaccer is getting pretty damn close to being able to connect the dots here and have a single platform that brings all of these disparate lines together. This is the dream. I would only add that it can't be just the primary care doctor. Everybody has to be everybody on the care team needs access to this. So this data activation platform and a unified record, as long as it's accessible to everybody, that's going to be the holy grail to make this work.
I love it. I love the graphic. A few things I point out that jump out at me that I really enjoy. The open innovative applications. I really see that as the future of analytics and pop health is moving from what really has been EMR-centric health tech to something that's a lot lighter, a lot more flexible, and not only liberates the data, but creates a community of developers around that data. And that excites me, and I think we're only at the beginning of companies similar to Innovaccer that are interested in having platforms or even apps that live on platforms that are not encumbered by the EMR, but at the same time seamless with it. I really like that the patient is at the center here, and from a data standpoint, I am very big on both liberating the data, but also that the data at the end of the day should be accessible and belongs to the patient, that your data is your data. There are a lot of folks working in that space, even though it's especially hard to get patients to use the patient-facing applications that exist. But I think once the applications meet the patient to what their usability standards are, if they're easy to use and intuitive and useful, folks will use them. But the market has to catch up with where folks are here. And then on the left side, yeah, I love each of the categories. I said earlier that some of them would not have even been seen, such as health plans. I love that health plans are getting more involved with clinical data now. You could not say that 10 years ago. And then the social determinants, patient-reported outcomes, community special services, all these types of information are coming together to really create a health data system, not only healthcare, but really focusing on health of the entire person. And that's beautiful.
No, I want to make a comment here, particularly around this application issue. You know, we've always been so application focused, so we have point solutions, the EMR, the pharmacy system, the the application we give a person on for scheduling, whatever, thousands of applications. Nobody thinks about bringing all the data together. We at Innovaccer, we conceptualized this idea for the company as two words: innovation accelerator. And this point at the very bottom right about open applications is really about creating an API for organizations and people to develop their own apps and kind of move in the direction that we all use our phone, where we can download the apps that we need to use. The data stays the same. We just want to use what makes sense for us and connect to the ecosystem. So innovation accelerator, that was the foundation of our company, Innovaccer. And love the dream. I'm really pleased to hear that this resonates with everybody. So let's move on to this idea that there's a lot of work still to be done, and there's a lot of challenges as well as opportunities. So let's flip back to David and say, you know, where are the challenges that people face? You know, what are the key challenges we need to tackle, and what are some of the things that we might think about for opportunities?
Yeah, well, this is a great summary of pop health management, the priorities, barriers, and strategies. I think among the challenges, David Nace, is how do you prioritize these strategies? Because you can't do everything all at once. So this is I think where the leadership comes in. Let me give you an example. So when we say patient-centered data collection, well, what exactly does that mean? I think that is a really important question. Does patient-centered mean we are connected to every community organization and we're searching for the zip codes with the poorest health outcomes? Does patient-centered mean we're focused on the patients who are in the value-based payment program only? So how do you rank order the strategies? I think that's a really important question. Creating that unified patient record, well, I think we just did a good job sort of describing how critical that is. But look, how many times have we all heard, this all sounds wonderful, but we're still in the middle of our Epic, Cerner, Allscripts installation, right? So I think a lot of places are still dealing with the basics of an electronic chart, let alone creating the unified patient record, developing decision support tools. I mean, so summary, how do you rank the strategies? That takes leadership. I think in terms of the barriers, this is probably an incomplete list of all the barriers. I think another big barrier, which I know I've been emphasizing, is the culture of physician practice. If everybody's been taught to be an autonomous decision maker with very little closure of the feedback loop, where every decision is an expression of physician autonomy, I think that's the biggest barrier we still face, culturally speaking. So then you can tackle the barriers that you've got listed here. So it's a tall order, and I'm not surprised that, you know, again, great data that you've shown in this webinar, 40% are making some modest progress in value-based payment, and fully 60% have no aspect of artificial intelligence currently implemented.
Well, Jesse, you've given us a vision of where we could go. What are some of the opportunities if we start executing these strategies?
Well, the end opportunities are really patient satisfaction, physician satisfaction. David's point about leadership. Here at Chess, we spend a lot of time thinking about how we can implement programs and initiatives that really remove the physician abrasion, but give the frontline physician something useful that will help them take care of patients better. At the end of the day, we are judged by CMS or the payer's understanding of quality and clinical cost. But the real judge, why we all got into this space, is help patients do better. And we do that by supporting that care team. Central to that care team tends to be a physician or a similar provider. So when you're enacting data analytics that are correct and are using fresh data that matter, when you get to the point where you can run machine learning algorithms, do deep learning, have neural networks, use predictive modeling to make your physicians and your, like that point, the second role about decision support, like your really good population health decision support should be predictive. To get there, you have to have good data. But when you're doing that, your outputs should be to any user, whether they're a physician or other extender, information that matters, information that they will use and be happy to use, and information that helps that inpatient, whether it's clinical or whether it's social services directed. And your system, by what you know about the patient, will be able to guide you. And does this patient, is their immediate need more social or is it more clinical? And just an acceptance that the two tend to overlap for so many folks.
Hey, David, Nash, I know we'll be successful when the patient-centered data goes like this. We know Mrs. Jones hasn't been to the office because she lives in a 5-story building and the elevator's broken and she can't maneuver the steps. And we know this because the driver of our van who goes to pick up patients reported this data at morning report because he was a part of the care team. That's patient-centered care. The rest is, sloganeering.
Absolutely. And, I think we can learn from some things they've done in other countries as well. We just need to get innovative. In the UK, they've leveraged the Postal Service, who know everybody, that they go to their doorstep and they can check on patients and ask questions and collect data. So all kinds of things we can do beyond the traditional clinical system and thinking beyond the walls of the hospital and the clinic, the practice. And in an upcoming webinar, we will talk more about that because we are working, helping to connect a connected care framework, just as we are at Chess with many of the ACHs, the organizations that are focused on bringing the community into the equation. And we'll do that in an upcoming webinar. Listen, these key elements, physician education. David, you've done this all your life, as you mentioned, and really done a lot of work. Advanced data, we've both talked about that. And, certainly at Chess, we've shown how better incentives using these combinations of, better educated people with good data can really be successful. We're going to turn to the audience questions in just a second. But David, I think you and I will both be at places where people can come meet us all in person. You want to talk about that?
Yes, thanks for bringing that up, David. I'm really thrilled because I would really like to thank everybody who spent time with us and get to meet more colleagues. So on March 10th, we'll be at the Innovaccer booth at HIMSS. And HIMSS is crazy, as I'm sure many of our listeners know. But if you want to seek refuge with the two Davids, Nash and Nash, on March 10th, we'll be at the Innovaccer booth, God willing, at HIMSS. And then, of course, I'd love to see everybody at the 20th anniversary of our Population Health Colloquium in Philadelphia. Unbelievable number 20. We had 75 people in an auditorium on our campus 20 years ago, and last year we had more than 700 persons at the beautiful Lowe's Hotel. And that, of course, is March 31st 31 and April 1. So 2 touch points, March 10, March 30, 31, and April 1. I hope we'll get to see as many of our listeners as possible. Come say hello, shake our hand, agree, disagree. It'd be really a great opportunity.
Great, really great, really appreciate it. You know, March 10 is in Orlando for HIMSS, big conference, lots of people. We are currently in, I think, booth 2014. Come see us, and then obviously Philadelphia for the Population Health Colloquium, and I'll be there as well. So let's turn to the audience questions for both of you. First question that I've got coming up here is, are you suggesting that putting providers in economic risk is necessarily a good thing? Let's start with you, Jesse.
Oh man. So Nash here, I'll go first. I'm not only suggesting, I'm saying that with the appropriate tools, if we bear some of the economic risk, there's 30 years of health services research evidence that says that's the only way to change clinical behavior in the correct direction. So coupled with good data delivered in a non-punitive way by a peer with severity adjustment, all the attributes that Innovaccer has, that's the way we're going to improve outcomes, reduce costs, go upstream, and deliver value. If anybody knows a better way, I sure as heck would like to hear about it.
Yeah, I think reading the public health record and clinical cost record for the U.S. has shown that the opposite, having providers at minimal or no financial risk, has not been for the best. And the reason we're pointing in this direction is, yes, because of the wealth of evidence in this space. And I think we both agree, yes, having providers at financial risk does make sense from a health care and economic perspective.
Sounds good. It makes a lot of sense. It sounds like the 30 years plus of evidence points in this direction. And as David is our good friend, Dr. Paul Grundy, our Chief Transformation Officer here, often says the only way to herd cats, physicians, is to move the food. So it really is about changing the monetary structure. Next question. How are larger organizations addressing provider attribution? So, provider attribution is, who's responsible for what patients. How are large organizations addressing provider attribution? Patients are seeing lots of docs.
Well, Nash here, so certainly the big delivery systems are doing it on a team basis. So patients are attributed to, team 1, team C, whatever it is. And I think that is probably a key learning for the future, how we're going to do this. It's more complicated with the Medicare population because of the rules and regulations. But I think either the pod, POD, or the team, I mean, in our ACO, we've got the docs divided into various pods. So this is evolving, I think, into explicit recognition of the team function.
Yeah, I'd say I have seen and been involved in the same, and would also say there's a layer beneath just who is responsible for this patient's care. Once you get into the quality metrics that are gates for a lot of the value contracts, and depending on which measure it is and this patient's background in the measure, the physician who is considered, or a group of physicians are responsible, will depend on the measure. So there's sort of global cost quality attribution, and then there's a deeper, more granular level of attribution that we've had to do work on. But the question of attribution, it almost causes a reflexive furrow of the brow, because so much time and thought has gone into attribution, and it's almost impossible to guess what a provider and a patient see as their patient and their doc.
Great. Well, these have been great questions. There are obviously many more, but we only have time for a few. This concludes our webinar. thank you both, gentlemen, for participating in this discussion of population health management, value-based contracting. It's been great. Really appreciate it. And come see David and I at HIMSS and at Population Health Colloquium. Jesse, thank you very much. David, thank you.
Thank you.
Thank you so much for the invite. And Chess is sponsoring a Move to Value Summit October 13th and 14th of this year, but otherwise next year at HIMSS.
Awesome. We'll promote that as well. So with this concludes the webinar. For the audience, we had a great turnout. Thank you very much. We'll see you at the next webinar. Take care.